It's an absolute honor to be presenting to you today, Dr. Nahid Mohammed. Dr. Mohammed is a board-certified periodontist. He's practicing out of Oakville, Ontario. Dr. Nahid completed his dental degree at the prestigious Boston University Goldman School of Dental Medicine. After completing his dental degree, Dr. Mohammed went on to further specialize in periodontics and implant surgery, completing his residency at Case Western Reserve University and University Hospitals in Cleveland, where he completed a master's degree in regenerative medicine, focusing on PRF and its healing properties for soft tissue and palatal wounds. Dr. Nahid has particular interest in minimally invasive and digital approaches to surgery. He has published many articles and co-authored a textbook on digital approaches to minimally invasive surgery. Dr. Nahid is also very active on Instagram, by the way, and he has incredible, inspiring, and educational posts. It's a great account, lots of bloody pictures that we all enjoy. So I urge everyone to check that out as well. So Dr. Nahid Mohammed, everybody.
All right, let me just share my screen. Okay, guys, everyone can hear me well?
We can hear you loud and clear, Nahid.
Okay, all right. So I've just closed my window, so I can't really see any of you guys, so I can see my screen, okay? So if you have any questions, just probably have to shout out. So today I'm going to be talking about bone augmentation. It's one of the things that I tend to, enjoy the most out of everything that I do. It's one of the most, I think, of all the procedures, it's the most challenging, but then it's also, you get a lot of joy when you open up a site and you see all that bone. And those of you who do bone grafting surgeries know what I mean, okay? Let me just minimize this. All right, so just want to start off by even just saying thank you to the guys at Dentistry for giving me this opportunity and giving me this chance to showcase some of the things that we do, okay? So I'm going to start off by just giving an introduction of my practice and what I do so people get to know more about me. So this is one of my practices. I miss this place, but hopefully in the next few weeks we'll be getting back to work and things will be different. But I think being away makes you appreciate, the work and what you do. So hopefully in a few weeks we'll all be back in our offices. Okay, so this is my practice in Oakville. It's rather new. I work out of two practices. I have this one here in Oakville, which is just me on my own. And I work with a larger group practice. I'm a partner there as well with two other partners in Mississauga called Periodontal Associates. And if any of you guys are in the area or in the West End and want to work with us, here's our contact information. So feel free to reach out. Like Wakar had mentioned, I started an Instagram account a few years ago, probably about 2 years ago, and it became a way, someone had mentioned starting it as a marketing thing, and it became a way to just kind of post my cases and have sort of a mobile sort of online portfolio that, as a specialist, anytime someone wants to see some of my work, it's easy to just pull out and just have them take a look. It also turned into a really good learning tool. I've learned a lot. I've made a lot of friends. Everyone on there is really, very open and friendly and shares their thoughts and ideas. So I actually have a huge network of colleagues from all around the world now through this. So if any of you are interested or have Instagram, I definitely do recommend starting one up or getting into the space so that you can learn a lot more, pretty much at the tip of your fingers. So today I'm going to talk about, bone grafting. But bone grafting, a patient doesn't come into your office and say, I want a bone graft. They want something else. They want function, they want teeth, they want aesthetics, they want to be able to eat and talk and speak well. And these are, our goals of dentistry in general. And implant dentistry today, regardless of what state the person is in, there's usually some sort of treatment plan or approach you can give them to treat their needs. And it could be anything from a single unit implant to like a full arch all on four case. And like I said, patients want teeth. They don't care about the details. They don't care about what, whether you need a root canal or core buildup. They're just like, I want my tooth and I want it to look normal. I don't want to walk around having everyone say, oh, that's a fake tooth. So these are the key things. So wanting something to look natural means that we have to rebuild contours and tissue. And this is where augmentation comes in, and this is why, we do a lot of guided bone regeneration. I get a lot of patients who come in and they say that, oh yeah, I was told that I don't need bone grafting, they can get an implant in. But, when we look at a case, it's not about getting the implant into the bone. It's about having the final prosthesis look natural and healthy. And so sometimes bone grafting may not be needed just to stabilize the implant, but rather for, tissue contour. And so, we know that, if you place dental implants, you see this in your own practice. And if you don't, up to 40% of dental implants out there, the cases do require some sort of bone grafting or bone regeneration. And this is the reason why is because, you have these dimensional ridge changes. When a tooth is removed, there's no stimulation. And so there's no stimulation of the bone. It goes through a resorptive process. Extraction sites usually lose majority of their dimensions and their volume within the first 2 to 3 months. And then usually over the course of the years after, it's at a much slower rate. We lose more width, horizontally than you do vertically. And all of these are then further, exacerbated by other processes like, whether a full thickness flap was, reflected. This means that you're removing the periosteal blood supply. How healthy is the patient, whether they have any metabolic bone diseases, their lifestyles, are they smokers, the site anatomy, was it a large, tooth, was it a buccally oriented or, prominent root, what is the biotype? So all these things affect the amount of bone loss that you get. And so, what we know from Schropp's, landmark study, looking at what happens when you pull a tooth out of the socket, we know that, you get a 50% almost reduction in the socket width in the first year. Most of the bone loss, like I mentioned before, happens in the first few months. And you do get a little bit of vertical loss, which is usually about 1 millimeter or so on average from a study. But majority of the resorption is, buccally and horizontally. And, we want to ask why do we lose more bone on the buccal and not on the lingual, And the reason is because a socket, the lining of the walls of a socket, that bone is called bundle bone. And bundle bone is usually receives its blood supply from the PDL, which is around the tooth. And so when a tooth is removed, the PDL is removed with the tooth or destroyed. And so the blood supply to that bundle bone, which is quite thin, is removed. And so what happens is this bone without any blood supply tends to break down and resorb. And so on average, majority of the buccal plate is mainly bundle bone in some cases. And so when the tooth is removed, when you remove the blood supply, as it remodels, you will get resorption. So this is why, we get more buccal plate resorption than lingual. And if you see the image on the top corner, you can see the difference in the thickness of the buccal and the lingual plates. So bone requires stimulation to maintain its rigid dimensions, to maintain its density and its form. Teeth themselves provide compressive and tensile forces to the surrounding bone, thus, giving it stimulation. When the tooth is removed, that stimulation is removed. So you get these, a decrease in the density of trabeculation. And it's almost like, osteoporosis, you get that spacing and lack of density in the trabecular bone. And so you lose volume. So the same thing happens, when you remove a tooth. And so as this happens, you get resorption. Now, a dental implant, this causes, stress and strain to the bone, just like sort of like a tooth is. So, this can sometimes, once it's put into bone, it can reverse that damage that's been done by lack of a tooth. And we've, studies have shown that you get an increase in trabeculae and density while the implant is inserted, as long as it's functioned and it's loaded correctly. So, basically what this means is, implants do maintain bone and width and height. So as long as they're kept healthy and it's physiologic, the force, everything is maintained nicely with implants. So part of my, when we look at teeth and lack of ridge volume, we have two options. Option one, when you remove a tooth, is preservation. And this is usually when you are there and you're removing the tooth itself. And option two is augmentation. Now, augmentation is usually because the tooth has been removed and the resorption has already taken place, and now you have a ridge that's quite atrophic and deficient, or there's a massive infection and a lot of the bone around that plate in the socket has been damaged. So today we're going to talk mainly about augmentation, but I'll give you an example of preservation just so you guys see what we mean. So we do treat, majority of my work now ideally would be preservation, because you want to maintain the contents that are there. So here we have a maxillary molar. It's obviously is fractured, the crown had broken off and the tooth wasn't restorable anymore. So we opted to go the way of an implant. Now, in this case, we plan to do an immediate implant. So the tooth was atraumatically extracted, and you can see the nice wide septum there, which is, why we plan to place the implant immediately. The osteotomies, you usually started with a pilot burr, and then in this case, I used denser burrs to widen the osteotomy. And this burr sort of uses a concept called osteodensification, where it turns counterclockwise and it compresses and widens the bone rather than cuts the bone. And so you preserves enough bone so that you can actually stably place your implant with a good primary stability. Here's our implant. Implant's placed into the site with a good primary stability. And then this is an on-one abutment. So in cases like this, this is an abutment that gets placed directly onto the implant so that the implant abutment connection is a final connection. So once this abutment goes on, it doesn't come off. The crown then gets attached to this abutment. And the concept is that, as long as you're not disrupting the connection between the actual implant platform and this abutment, then there's, lack of bacterial penetration and, lack of bone remodeling and bone loss around the crest of the implant. So here's our on-one abutment. This is a Nobel BioCare product. So it sort of turns a platform bone level implant into a tissue level implant in essence. And so once we have our on-one abutment, it's torqued to the right specs according to the manufacturer. And then now this abutment is not removed. This is a temporary abutment that we'll use to create our customized healing abutment to maintain the tissues. So the temporary abutment is screwed on place. And then we use that temporary abutment to create a customized healing abutment. Now, the point of the customized healing abutment is to support the tissues and the emergence profile of the natural tooth. We see healing abutments, they're very circular, round, and no tooth is shaped like that. So customized healing abutments made chairside give you a better final aesthetic result, as well as a better preservation of the soft tissue profile. And so this is the customized healing abutment in place. And so this is the whole process. As you see, tooth is removed, implant osteotomy, implant, bone graft is placed around the implant to preserve the socket, and the customized healing abutment to preserve the tissues. So, this is what we call preservation of ridge dimensions. And usually after this, in a few months, the tooth will be ready for the final restoration. Now, the majority of my lecture will be talking about option 2, which is augmentation. So these are cases that, come in and they require some sort of ridge augmentation to build up the ridge to make it amenable for implant placement. Okay. Now, the concept of GBR, comes initially from studies back in the day done for the purposes of periodontal defects. The concept of GBR came from treating bone loss around teeth. And what it is basically is you get the right cells that are able to grow into bone in the right place. And you want to keep the cells that don't grow bone out of it. And this is what the whole concept of a barrier membrane is. So, we want to get osteoblasts into the defect site, and we want to keep out epithelium and fibroblasts. Now, there's 4 main principles for a successful bone regeneration. One is exclude the unwanted cells. You want to maintain the space of the defect. You want to have a stable clot. And you want to have a closed environment, which is primary wound closure. Okay, without a closed environment, you get bacteria and things getting in there, which can then damage or affect the amount of bone loss. So what happens when you first, create a defect and do the procedure? So the first 24 hours you get, the material and everything is placed into the defect, and, you get a blood clot that forms. And usually what happens is the blood clot then releases growth factors and chemical signal cytokines to attract neutrophils and macrophages. These guys come in and they start to remove the clot and break it down and put in granulation tissue. Granulation tissue is that soft tissue that is now, a scaffold with blood vessels into it. Now, through these blood vessels, we get more stem cells and nutrients into the site, and you start to get cellular differentiation when you get osteoblasts now starting to lay down new bone or osteoid. Over time, this osteoid then starts to get a little bit more organized and mineralized and harder, and it turns into, lamellar bone. So usually this immature bone, we call it woven bone, and then as it sort of gets more organized and mature, it's called lamellar bone. And then this then continues to differentiate and organize itself into cortical bone, trabecular bone, and bone marrow. And usually this happens a few months after the surgery. Now, Dr. Wang in 2006 made an article that sort of summarized these concepts of guided bone regeneration into 4 principles, and he called these the PASS principles. Okay, so P was for primary wound closure, so meaning that without a closed, stable environment, you're not going to get adequate bone growth. Angiogenesis, basically you need to have blood supply into the area in order to grow bone. Stability of the clot, meaning that your graft and your material has to be stable. If there's any movement or micromotion, that this creates an entrance for fibrous tissue ingrowth and resorption and loss of bone volume. And then space maintenance. If you want to grow bone into a certain area, that space has to be maintained. If it collapses, you lose bone volume. So we'll go through all these principles, with each one, going into them a little bit detailed so that you can understand them, because this is sort of what, you follow these principles, and this is what guides pretty much any bone grafting procedure. So primary wound closure. It's basically, an important principle for any type of regeneration. You have to have a closed, undisturbed environment. Anything that's open or membrane shows, you get, first of all, if a membrane is exposed, you get resorption of the membrane. So it starts to break down. It gets contaminated with bacteria. This then can affect the bone graft, which can get, resorbed bone graft material. You can get bone graft material falling out, and then also you risk infections. If you have a nice closed environment that's sutured well, then you also then prevent openings of the tissues, dehiscences, during the healing period, which would also prevent infection. In order to get a good primary wound closure, you need to have passive tissue and passive flaps, and a correct flap design. Some of this is what was discussed by Tina earlier in the lecture. You have to have a released flap, and it has to be sutured correctly in layers to be able to get a good closure that's stable. So here's just a short video just showing, release of the flap. You can see we're incising the periosteum very slowly. I'm not going too deep. Hence, you see there's not much bleeding at all. And you can see as I'm pulling the tissue, as I score the periosteum, it's already naturally just stretching because the elastic fibers are now released. Once I open up the incision, then I like to use this back action chisel. It's an interesting and easy tool to use. You just go into the score and you just pull on the elastic fibers of the connective tissue and it just stretches. And it's an easy way to do this without any fancy instruments and without damaging any of the nerves or anything like that. And literally that's all that's needed to score the periosteum. And you can see it was very little blood. I like to do these personally, usually in the beginning of the procedure, as soon as I lift the flap, because if there's any bleeding, it has time to clot and it allows me to work, by the time everything and the bone grafting and everything is done, I don't need to worry about releasing the flap then when everything is tightly packed in there. It's just easy. All I have to do is go ahead and close the flap. This is just showing another video showing, once the buccal and lingual flaps are released, you can see I can lift them way over the ridge, so I have lots of space. And, primary closure of the site should be very easy. Most people, most beginners this is like the biggest, I think, factor that most beginners don't get right, which causes a lot of their bone loss or bone grafts to fail, because they just don't have passive closure of the site. So our next principle is angiogenesis. Now, angiogenesis, usually, the first 24 hours, we get basically a blood clot that forms in the space. The initial blood clot is removed, and you get all this granulation tissue that's formed. Just give me a second because I'm fasting and my throat is dry. So the granulation tissue is rich in blood vessels, and this is what, like I mentioned before, brings in the osteoid formation. These new blood vessels then bring in key cells and nutrients for bone regeneration. When you have a ridge, sometimes people do these decortications into the bone, and this allows communication with the marrow spaces, which allows more blood supply and growth factor to the cells. And these cells, they usually come from the periosteum, the endosteum, and surrounding mesenchymal cells in the bone in the area of the defect. So basically, overall, this means that, if you don't have blood into the site, you're not going to get bone. Space maintenance. So space, if you have a larger defect, that site has to be maintained. It has to be maintained, and it also has to be closed up with barriers. Barriers meaning that, you want to keep out epithelium and connective tissue. The reason why we want to keep these out is because bone growth is very slow. Osteoblasts lay down bone at a much slower rate than the growth of epithelium and connective tissue. So if you don't have a barrier and you don't have the space maintained and protected, you get soft tissue ingrowth, meaning that, these cells will grow into the space before the bone has a chance to grow into it. And, basically the maintenance of the space can be done by a number of ways. It can be done by the bone graft particles itself. It can be done by a stable or rigid reinforced barrier membrane. You can use, cortical bone plates or bone blocks, tenting screws, titanium plating, and even titanium mesh. So all of these are different ways you can maintain the space and the dimensions of your defect. And, this is very important, especially when you're doing larger reconstructions where there's, a large vertical component to the defect. So some pictures you can see here. Here's a titanium reinforced membrane. So these membranes are non-resorbable. They're made out of PTFE. They have titanium struts, sort of bendable titanium struts built into the membrane. So they're flexible and you can bend and shape them to the right size and shape that you need, which will sort of hold the dimensions of the defect. And they have to be usually either tacked or screwed in place. Here's a tenting screw. This is a vertical defect. You can see how the tenting screw helps keep the bone graft and the membranes in place. It prevents things from sort of collapsing down into the defect. Here's a titanium plate. This is another vertical defect. A titanium plate will then help protect that vertical defect and protect, again, the graft and the materials from kind of pushing down into the defect once the flap is closed. And then here we have cortical bone plates. So bone plates themselves are, rigid barriers. They're sort of biological membranes in a sense because, they prevent, cellular ingrowth. You don't get epithelium and soft tissue growing through these plates, and they're rigid and they protect the defect in the environment. And you sort of allow bone, if you sort of place them where you keep space between the existing ridge and this plate, it creates almost like a box around the defect, which will allow bone to slowly grow underneath it while it protects from the soft tissue on the outside. Now, stability of the clot. This means that once you have your bone graft and your blood clot into the site, you want to make sure that it's stable. There's no micro movement or motion in the area. When you have this, and you also want to make sure that you keep cells out, because when you have motion, especially if you have, for example, the PTFE membranes, if they start to move, even though they're barriers, the movement itself causes micromotion, which can cause the soft tissues now start to grow in. So we want to keep our initial clot stable. You want to keep the bone graft and everything stable. You don't want things to move around. As things move around, you get loss of bone particles, fibrous ingrowth, and more resorption. And this can be done by a number of ways. You can use sutures to hold down the membrane, tacks and pins that we, sort of like I showed before, mesh that is sort of stabilized as well by tacks and pins, the PTFE membranes again, and screws. So all of these, basically you want your bone graft in there nice and tight. The other thing that helps with this is biological modifiers, things like PRP and PRF, to create sticky bone and create these membranes that hold everything in place. So here's a video of just sutures used to hold a membrane in place. So you can see as I move the flap around, there's no movement of the graft and the material. So it's a good and easy and a cheap way to stabilize your bone graft. So usually for horizontal augmentations, using suture is pretty predictable. Once you start to get to bigger defects, you need to have something a little bit more stable. Bigger defects like this, where you use tacks or bone pins to really stretch and hold that membrane tight. Here we have a BioGuide membrane, which is a native collagen membrane, which is a little bit elastic in nature. So this allows you to kind of hold and compress and tightly pin the membrane over the bone to keep everything nice and tight. Sticky bone. So sticky bone usually is created by, the patient's blood. This comes from PRP and PRF. This is bone particulate that you're seeing in the image. So you can see once it's formed into the sticky bone, it's almost like a moldable putty, and you see the bone particles don't sort of fly around. So when I use this stuff, it holds everything in place and it makes sure that the graft and the clot are stable. So it helps with that. So sticky bone comes from platelet concentrates. These are biological growth factors that come from platelets. We have our PRF plugs, our PRF membranes, sticky bone, and our platelet gel membranes or liquid PRF. So what do we get from all these principles? The secret to bone growth basically is you need to have a closed, undisturbed environment where the space is stable with the right cells at the right time, and you have to give it enough time for the cells to do their work. So if you have all of these factors in place, no matter what you use to stabilize the defect site, what type of bone graft material you use, as long as you have all the factors covered, you will grow bone. So now I'm going to talk about just how I treatment plan a case. Usually majority of the cases I get, I work from referral basis, are usually more complex cases, but sometimes, I like easy cases too. They're more simpler, but most of our cases are usually large defects. So when I see a patient, I see them in 2 appointments. The first appointment is to just meet them, see what the problem is, collect all my data. So what we collect is, medical social history for the patient, because I treat patients, the treatment approach I use is very patient centric. If a patient is a smoker or has some sort of, avid gym buff that, I know will not stop going to the gym, then I treatment plan a case a certain way. I take intraoral radiographs because sometimes I just like a PA as opposed to a cbct scan. I like to have both of them. We take clinical photographs just so we can take a look at the ridge clinically. I like to see how the tissues are, especially if the patient's left the office is a good reference. You have intraoral scans or impressions, either or, and a cbct scan. And then the patient's expectations, that's an important thing. You need to know what the patient expects or what result they're expecting. So I take all this data, I kind of get once, if you don't have a CT scan in-house, I send them to Canada usually. And so once I get all the information, I look at it all and I formulate my treatment plan. So this is now the planning and analysis phase. So this is where I take all that data and we look at what the patient's expecting and what's needed. And then we design our case. After speaking with the restorative doctor, usually, we talk about what the patient's expecting and we discuss what the prosthetic design is. So meaning the teeth, what type of prosthesis it's going to be and what it's going to look like and where is it going to be, Usually I take the impressions in the intraoral scan and we do a wax up or a digital wax up. And this is used then to guide my surgery. So I always work backwards. I look at the end result. We look at what we want or where we want the crowns. Then we look at the bone, we look at the soft tissue and the patient factors. And then all these are sort of put together and we decide on the treatment approach, whether I'll be doing bone blocks or a simple, particulate bone and membrane or tenting screws. So all of this then comes out to how we then execute it. So usually in between the planning and the execution is when I see the patient again for their second consultation. This is when we go over the treatment plan, go over the type of procedure I've recommended, the cost, the fees and everything, and then we go ahead to execute. And that means it's surgery time. So a lot of these steps, there's a lot of details. You can go through a whole lecture on just this page itself, but for the sake of it, these are all the things we look at. So this is something, what I like to call virtual surgical design. So I'm a big avid fan of digital dentistry. So a lot of the stuff I do has some sort of digital component to it. All my planning is done digitally if I can. Sometimes because I've just done so many grafts, if it's a simple horizontal augmentation, then no, I don't need all of this. I can kind of look at it pretty quickly. But doing this helps the patient understand what's possible, helps the patient understand what you're recommending and why. And it's a good patient motivator. Like, when they come in for that second appointment, I show them this treatment plan and discuss with them and they get value for their money. So when I give them their, the price tag for their treatment, it may be higher than what they're expecting, but they're getting more and they understand more. So they're finding value in the high cost, It's not like saying, okay, this is what you need, this is the fee, that's it, walk out the door. So this is what we do virtually. So from the cbct scan, we segment the jaw. Okay, and when we segment the jaw, you can clearly see, for example, in this case, there's quite a bit of a horizontal and vertical defect. What we do first is we look at where we want our teeth. And so this is just a digital rendering of some digital crowns. This is just done in the cbct software. Once we have the crowns or where we want the crowns, then the implants are placed in relation to where the crowns are. So now, we have our sort of prosthetic reference and guide, and the implants, in this case, this is where I'd like the implants to be. So looking at this now, you can see how much deficiency we are. So now with the implants in the correct positions, you see how deficient we are. So now I know that, okay, in order to get things to the ideal expected level, this is the amount of bone I need to grow. So what we do is we can even then digitally augment the bone. So this is a digital bone graft. That's the digital bone graft in place. So this is what I need to get there. So now that I know how much bone I need, I can decide what's the best way to approach this. And then to take this one step further, sometimes we then put it all together. This is just, the crowns, and then overlay with the bone graft and the implant. Now this is all shown to the patient so they understand why they need the bone grafting procedure, how much bone they need, and I explain the type of technique that I'll use. And then sometimes what we do is we 3D print a model for them. This is a 3D printed model of the jaw, as well as the actual digital bone graft. And usually, once we're done with the case, I usually give these to the patients. It's like a nice little reminder. And they like it, it gives them value for what they're paying for. So when I charge them, the few $1,000s, whatever their procedure is, they're getting something more than, they would expect. Okay, so now we're gonna go over some clinical cases. So we have a lot of cases here, so everybody likes to see clinical cases. So enough with the theory. So we'll start here. In this case, this was a simple, as you can see, the one tooth is not restorable, and there's a little bit of a horizontal deficiency here. So here, once the flap is reflected and the tooth is removed, we look at the defect. So this is mainly a horizontal defect. This is a very easy, predictable procedure. These cases like this, I don't even take cbct scans. I don't need them. It's just, very easy and simple. These are most easily done with a collagen resorbable membrane and particulate bone. So in this case, we used cortical allograft because I didn't want to wait months and months to go back in. It wasn't a huge augmentation, so for me at least. And what we did is, we wanted to be able to place the implant between 4 or 5 months. So the particulate bone is placed into the site. We usually overcompensate the amount of bone we put because you do get about 20 to 30% remodeling and loss of volume. The membrane, this is a BioGuide collagen resorbable membrane, which is placed into the site. And then I like to use sutures to stabilize and fasten the membrane. So here, this is one of my many different methods of suturing a membrane. So this, you can see how everything is nice and tight and held in place. So now I can, I'm not worried about the bone graft moving out of the defect site because the membrane is tucked over it, and the membrane is then stabilized by the sutures, which is holding everything nice and tightly in place. And the flap is then sutured. You can see just how Tina was mentioning earlier, a continuous interlocking suture on the top. You can see horizontal mattress sutures on the bottom. And then I like to do, if you look at the vertical incision on the right side of the page, you can see I have proline on the top, but then I use monocryl on the bottom near the mucosa because, like she mentioned, those areas are very tender and it's uncomfortable for the patient to go back in there and have to remove a suture or cut it out. After a couple of months, this is how the ridge looks. You uncover the site, you can see this is the bone volume you get. So you can see the bone graft is nicely incorporated into the site. It's remodeled nicely, and we're ready for implants. Implants are placed and sutured. So basically, this is an easy case. It's very predictable. We follow the rules. We use the bone graft material. We maintain the space with the sutures. We excluded cells with our barrier membrane, flap release for a nice, simple, closed environment. And literally in a couple of months, look at the amount of bone you have. So very, very predictable and straightforward and not complicated at all. Our next case here. So this guy came in. He came in wanting to get a better aesthetic appearance. He had lost a tooth. He had, some periodontal disease. It seemed to be under control, but the other central had quite a lot of bone loss, and we wanted something stable and predictable for the long term. So the dentist, we decided that, we can't restore this because we don't want to have an implant and lose this in the future and have to work on it again. So we decided on removing the central and building up the bone volume, and then putting 2 implants with some bonding on the laterals to kind of have everything flow a lot nicer. And so once we made our plan, we went ahead, we removed the tooth. You can see the ridge dimensions. We have not much vertical, but it's mainly a horizontal defect. Bone graft mixed with the patient's blood is placed into the area. Sometimes you can just mix it with their blood, which will start to clot and create a little bit more of a putty-like consistency. Collagen membrane placed, secured by 2 chromic cut sutures. This just to make sure that everything is sort of held tightly in place. flap is closed and secured. You can see the incision line is nice and closed, primary closure. Once everything is healed after a couple months, this is what he looks like on the outside. This is what he looks like on the inside. So you can see we've got nice large amount of bone volume. In this case, I wanted a lot of the buccal bone volume, not only for placing the implants, we have more than enough bone for the implants, but more for tissue support, because this is an aesthetic area. So usually anterior aesthetic areas, we want to have as much buccal tissue volume as we can, whether it be bone. If I can't get the bone, I try to build it up with soft tissue, because the more volume I have, it's like clay. You know, the more clay you have, the more you can mold and shape it into a more aesthetic appearance. And these are his two front teeth, so we wanted to have some sort of tissue there so we can build some sort of papillas to have a nice final appearance. So the implants are placed. Usually these are placed in with some sort of guide, whether it be digitally guided or an acrylic stent or guide provided by the restorative doctor. In this case, we closed up the site. You can see again, layered sutured approach. We had, it looks like it's simple interrupted, 4 of them across the ridge, and then 2 horizontal mattress sutures. And then once everything healed and he was ready, we basically uncovered the implants with 2 custom healing abutments. These were made to sort of start to shape the emergence, to try to shape and try to build some papilla. I also, it's not shown in these images, but we also slid a piece of alloderm onto the facial, the buccal of these, to create a little bit more volume. Now from this, after a few weeks of healing, you can start to see some semblance of some sort of papilla in shape. And now he goes back to the restorative doctor, and they go ahead and provisionalize with the full provisional, and then go out with the final. So once it's all done, this is what the patient looked like. So we did basically the 2 centrals are implants, and then I think it was composite bonding on the laterals. And so now you can see everything kind of flows better. You can see the nice thickness of the tissue on the facial. We went from having very little horizontal bone to having a nice large amount of width. And we went from a periodontally compromised patient with an unaesthetic appearance to something where he was happy to smile. So all these, there's lots of little steps that go on with this, but in our case, bone augmentation is a perfect example of you're building bone not just to hold or stabilizing it, but to create tissue profile and ridge, so that you have something to mold and shape for an aesthetic appearance. Here's our next case. This case, the patient must have had an infected tooth that ate away a lot of bone. So when they came, when it was time to replace the tooth had a large defect in it. You can't notice it when you look at it clinically like this, but you'll see once we raise the flap. So she was referred over to have the side augmented. Also, just a note, some cases you won't see any implants placed because they're sometimes sent to me just for the bone augmentation, and they go back to the other doctor because they want to place the implants. So if any of you out there do work with me or want to work with me, sometimes I just do the bone grafting and the patient goes back to you to have the implants placed. So here's the defect in the case. You can see literally it's a through and through defect. There's no lingual plate, there's no buccal plate. So this is a nice vertical defect. And so in this case, the key to this, why I wasn't worried and I knew that we'd be able to easily regenerate this bone is if you look at the interproximal bone, both sides have bony peaks almost to the crest. And so literally we're just missing, we have mesial and distal bone, we're just missing buccal and palatal or lingual bone. So what you see here is I tucked in a membrane into the lingual flap to create a wall or barrier from the lingual. The site is then filled with cortical allograft. I use cortical allograft because it has a little bit of a slower resorption time and a little bit more than cortical cancellous. And once the allograft is packed in place and packed into the defect, usually you can see I'm overcompensating with the volume. A membrane is then placed over. So the membrane kind of tucks over, it's shaped and tucked over the top and sort of tucks in over the membrane that was placed previously on the lingual. Now with these cases, I use 2 different types of membranes. the membrane on the lingual, it is a collagen membrane, but it's a different brand. It's a collagen membrane that's much more stiffer, almost like a cardboard appearance. In this case, it was OsseoGuard. OsseoGuard is a very stiff membrane. And so I wanted something with a little bit more rigidity. And then over the buccal and over the crest, we used a BioGuide membrane, which is a little bit softer and more elastic in nature. And then 2 sutures to stabilize and hold the graft in place so everything is nice and tight. So now, even like that video you saw earlier, if we move around the flap, that bone graft is not going anywhere. The area is closed up. And a couple of months later, this is what we re-enter. And you can see all the bone is all nicely regenerated and they're ready for implant placement. So we went from a complete vertical defect with total loss of buccal and lingual plates of bone to a fully regenerative defect. And again, this seems like it's difficult and complicated, but again, if you know the biology and you know the principles, and you know that we have, the 2 walls of bone on the buccal and on the distal and mesial, this isn't that hard at all, as long as you do all the steps correctly. Here's another defect that was sent to me. This is a patient who had a bridge that had fallen off. One of the teeth was not restorable, so they decided to put a crown on the mesial abutment, and then we're going to remove the distal abutment and then graft the pontic space. You can see the large buccal defect, likely because that tooth has been missing for a long time. Once we raise the flap, this is what we see. So you can see literally where that pontic space was, all that bone is atrophied. You can see, especially when you compare it to the extraction site, where there was a tooth stimulating the bone and where there's no tooth. So it's a clear example of the amount of bone loss and atrophy you get on the buccal plate when there's no stimulation to that bone. Also important to note how thin the buccal plate is compared to the lingual plate. So you see this is why we lose more buccal bone than lingual bone. So in this case, we used bone tacks to secure the membrane. Again, I used a resorbable membrane. This is corticocancellous allograft, which was placed into the socket and in and around the area. And the membrane is I usually tack these first on the palatal, and then we flip it over, pack the bone in, and then start to pin in different areas. We start in one corner, and then as I start to pin each corner, I stuff more bone in there and tighten it, and then pin the rest. And so it's all secured nice and tight. Everything is nicely closed up. And then a few months later, usually with these cases, I try to wait about 5 months or so. 5 months is usually enough time for it to re-enter. This is the side. You can see now the change in the volume just from the outside. The flap is exposed. You can see the ridge. You can see remnants of the old pins. And once the implant's in place, so you can see now we have a nice, thick, adequate ridge. So when we look at the site and we compare what we started with and what we ended with, you can see the amount of augmentation that was done. And again, like I said, most of these are fairly predictable, not really difficult at all, as long as you follow those 4 principles and you do the steps properly. It's, anyone can do this. Our next case, this is a posterior defect. There was a little bit of slight horizontal resorption and vertical resorption. So we had a little bit of both. So on something like this, usually I like to use a rigid barrier if I can, because it's a good way to maintain or get a good amount of vertical height. Because here, it's not like we have really peaks of bone to work with. So it's just a ridge that has sort of dipped over time. And in this case, here's just, you can see the lingual flap release. Now what I do is I take so we used a PTFE membrane, which is titanium reinforced. We fixate it with bone pins or tacks on the lingual. We pack our bone in from the buccal and over the ridge. Once the bone is packed, then the membrane is flapped over. The pins are held in place and tacked in there. And then the flap is closed up. Again, primary closure is important. You want to have primary wound closure. You don't want any chance of any wound dehiscence or wound opening or opening of the flap with these types of membranes, because it can cause the entire site to fail or lose a lot of bone. So with these, you have to make sure you get adequate flap release, both buccally and lingually, and you get a nice layered closure. So these types of defects, I like to wait a little bit longer. With these, we usually wait anywhere from 6 to 9 months. And so after that time period, we go in. This is what the site looks like now. You can see the difference in the width, the height of the tissues. This is us opening the flap. You can see the remnants of the membrane there and the tacks in there. Once we peel out the pins and peel off the membrane, this is a nice ridge of bone. You can see we have a nice height. You can see now the line is sort of straight from the ridge, and you can see the width there. Here we go. So we have a before and after. So these procedures are a little bit more technically difficult. It is, you know, hard to get that membrane pinned and adapted in the right place. You know, that I would say is the hardest part of these procedures, getting that membrane stable and pinned nice and tight. You know, once you have that, the rest is pretty straightforward. And if you have it secured, you know, one of the main reasons why cases like this fail is, one is the membrane itself is not secured properly and it's not stable, which results in movement over time. And two is the flap is not released enough to allow adequate primary tension-free primary closure, so that there's no incisions or wound openings or dehiscences during the healing period. This is another case. Now here, this is a case. So a lot of my practice now has to do with fixing failing implants or implants that are placed incorrectly or poorly, or just over time implants with bone loss. So in this case, you know, normally looking at a defect like this, I would opt to remove the implant, sorry. In this case, you know, I offered the pay. I said that, you know, ideally it'd be easier to just remove the implant. There's less risk. He didn't want to remove the implant. He's like, no, if you can grow the bone with it in there, please, I'd rather. So looking at the defect again, I thought, okay, you know what? We do have interproximal bone. There's no buccal or lingual bone, but the interproximal bone will help me. I will need some sort of rigid barrier to hold the lingual and buccal bone. So I thought, okay, you know what? I think I can do it. I'm a little bit confident. We'll give it a try. And since he was down, we did it. So first things first, with cases like this, we always want to disinfect and detoxify the implant and the threads. I don't worry too much about polishing them, because I want bone to grow over this area. Usually you polish threads that are going to be exposed in the soft tissue to prevent plaque retention. But if I'm expecting bone growth, it's not a big deal. My main concern is just to disinfect that implant surface. So use a buccal view of the defect. The implant is disinfected and cleaned up. We used, again, a cytoplast PTFE membrane, which is secured with a pin on the palatal. The bone graft is placed to totally cover the entire implant. And then the membrane is then flapped over and secured with the pin. So you can see how everything is nice and tightly closed. And let it cook for a couple of months. Here you see horizontal mattress suture, and then I think there was simple interrupted on the top, and then the vertical incision is closed with chromic gut. After a couple of months, here's what the patient comes in. This is what it looks like. Looks good. The tissue look good, nice and pink and healthy. Don't see any wound openings. We open up the area, and this is what we find. You can see as I'm peeling out that membrane, it's nice and solid. You can't even see the implant. Here's an occlusal view of the same defect. So the implant is totally buried in bone. Usually with this, I just use a small explorer, usually a Orban knife, to kind of poke into the softer bone to kind of find the top of the cover screw, and we just kind of pluck away the bone, and then I can unscrew the cover screw and place the healing above. Here's the facial view of the same defect once we've uncovered it. So you can see we got a nice amount of bone regeneration. This is when I breathe in. I'm like, thank God. So healing abutment is placed and the site is closed. So in this case, you can see the before and the after. And again, it looks like it's very difficult and unpredictable, but really it's all based on those principles in biology. Our next case, we're just gonna show how I use some of these biologics, from platelets to modify and shape and hold bone graft materials in. So these are PRF membranes, and these are PRF clots. A lot of my lateral window sinus lifts are now all done with PRF. The only reason is because it's just so much easier. The membranes, if you have any tears in your membrane during lifting, the membranes from the PRF are really good at patching and closing it up, so I can still continue on and not have to abort the procedure. You can see our sinus window is made, the membrane is reflected. The sticky bone is great to place into the site because you can literally just pick them up with the cotton tweezers or pliers and just kind of stuff them in very quick and easily. And usually with sinuses, you can see this is a mix of allograft and biowas. You see those really white chips there, those are biowas. And then I take some sticky bone on the outside because we wanted a little bit of buccal bone augmentation. And you can see I can literally just put the bone in there and take a picture and it's not gonna move away. I use that platelet gel membrane. This is almost like a saran wrap. It kind of easily coats over the bone graft and seals it nicely in place. It kind of wraps it tightly in there. And then over this, we put our PRF membranes. And this side is closed. And after a couple months, we ran to replace 2 implants. Now, this lady was having implants to hold locator attachments for a removable denture. That's why I never really opened the entire flap because the majority of this was just sinus lift bone. So unfortunately, I don't have a good picture of all the bone that was grown, but take my word for it. Here's another case. Lady came in. This lady, she had a history of oral bisphosphonate use, and she had implants in this area in the past, and she mentioned that they all failed. So when she came to me, we opted to use these platelet biologics because I wanted to use everything I could to have some growth factors in there to increase our chances for blood supply and angiogenesis and regeneration at the site. I didn't want her to have any sort of risk of osteonecrosis or any poor healing, and especially with her history of previous failed implants in the site, I thought we'd take a little bit of a conservative approach. I didn't want to use anything non-resorbable. And, so we decided that, we'll use our sticky bone and PRF membranes. So here's our sticky bone that we made. Usually these are made just from drawing the patient's blood right before the procedure. Our PRF membranes. Once the sticky bone is shaped and molded, this is it right there. This is our preoperative ridge. Once the site is cleaned, the bone graft is molded and shaped and placed into the site. Once it's placed and shaped, we use our PRF membranes over that, and then the site is closed. And then we usually let these sit. Now with PRF, sometimes I find I don't have to wait as long. I've gone in as soon as 4 months to re-enter and place implants. I think this was between the 4 and 5 month mark. So once we re-enter, this is the new implant in place, and this is the newly augmented bone. So you can see we got a nice amount of ridge. It looks nice and clean and healthier. And I got plenty of bone for the site. So what we started off with and what we ended off with. Our next case, this young lady, she was in her 30s. She had an unfortunate accident. She was actually down in the Dominican, and I guess someone at the pool was drunk and they picked her up and they slipped and she fell on her face right on the concrete and broke her 2 front teeth. She had then, I guess, returned back and gone to see another specialist where they attempted to do some bone grafting, but it failed. And then this is an aesthetic area and she just wasn't happy. So somehow she got to see a prosthodontist who we work with, and that's how I got the case, because the prosthodontist sent her over to us. So this is usually with anterior teeth, even if a vertical defect doesn't look that large, with anterior cases, every millimeter counts, because if you look at it, she already has very long teeth. We want to make sure that we don't have to make them any longer. The other thing is these are, a central and a lateral, a very difficult area to treat and to make look natural. If you're 2 centrals, it's a lot easier because you have symmetry and, the midline. But when you're working off to one side, they're going to look at the symmetry and they're going to compare the right and left side. So we have to build enough bone volume to be able to have her left side look like her right side. So in cases like this, I don't want to risk losing any bone. So we usually, I'm a big fan of bone blocks. So I tend to use them a lot, which you'll see in the next few cases. So in this case, we use what I call a box technique, okay? We basically have a bone plate on the buckle. We take autogenous bone, shavings usually which are harvested by a scraper and are packed into the void. And then we take another plate and we kind of seat it over the ridge, almost like we're creating a little box or a sandwich. And then those are screwed in. And then I usually take some particulate bone and just pack it into and over around the edges, and then everything is closed up. Now, this is usually because these are bone plates. Most of the time, within 4 months, you can re-enter the site. So wait a couple of months, we go, and you can see now already the difference in the way the ridge looks and the tissues look. So this is how we re-enter the site. Now, cases like these are aesthetic cases. So these usually go through different layers of augmentation. We usually do bone grafting. Then when we place the implants, we do some additional bone grafting. Then we do some soft tissue grafting. And then we go into the provisional phase and we start to shape. So these are quite intricate steps, and they have to be followed and done correctly to get something looking good. But the focus of our presentation today is bone grafting. So this is just, where we end up. So you can see the before and you can see the after. So we have a nice thick ridge and volume. So now my goal is to take this from here. I don't need any more bone, but I want to build as much soft tissue. So when we place the implants, we're going to place some soft tissue to augment the tissue ridge, so that now the prosthodontist has more than enough tissue to start to shape papillas with the provisionals. Here's another case of a vertical defect. This lady had an implant that was placed somewhere else. I don't think it was even in Canada. It was failing. As you can see, the small amount of pus exudate from the marginal tissue. The tooth on the distal there is a hopeless tooth, a lot of bone loss, and we're looking to extract that. It was actually cracked as well. So what we did first in this, if you remember, if you look at the tissue, you can see there's no keratinized tissue around the implant and around that mesial portion of the defect. So here, my first step was to remove the distal tooth and to do a free gingival graft to get a little bit of keratinized tissue. The reason I did this is because this is a vertical augmentation. So when we do vertical augmentation, I need to have thick, healthy tissue so that I can release the flap and secure it and close up the site. Because one of the big killers of a vertical augmentation is your flap opening. It basically means the case is going to fail. So our first step is just to prepare the environment. So that's free gingival graft and extraction of the distal tooth so that I have the tissue to close up the site. Now I'm ready for the surgery. So once everything is healed and remove the tooth, I go in. So now you can see the amount of bone loss around that implant. You can see the extent of the vertical defect that we have. We have a vertical defect mesially, and it sort of wraps all the way around to that distal peak. The good news is the peaks of bone on both sides, on the mesial of the defect and way at the distal, if I draw a straight line between those, that's where I'm expecting to get the bone, because we have nothing on the buccal and lingual and it kind of dips in there. So with cases like this, here's just another view once the implant is removed. I use a bone plate to create a wall. We try to put one on the buccal and the lingual, and it's fixated with screws to just hold everything in place. And that creates almost like a trough. And then in the middle, we fill the trough and cover with a membrane. So here the trough is filled with particulate and a little bit of autogenous bone chips. And then collagen membrane is closed over it. And the flaps, usually the flaps were released prior to doing anything. The flaps, so at this point, looking at it the way it looks right now, I don't want to have to release my flap now. So it's always done in the beginning, so it's out of the way. Because now all I have to do is just release and close. So now you can see where the ridge and how much height we've gained and how much tension-free release we need to be able to close this site carefully. And then we let this cook for a couple months. And when we re-enter the site, this is what we find. So you can see nicely remodeled bone. You can see even the bone is even creeping up over one of the screw heads. So at this time is when we go ahead, we remove all the screws. So you can see the defect we started with and the and the bone that we grew. So again, this is a little bit more complex and a little bit harder, but if all the steps are done correctly, it is predictable. Okay, because remember, all we're doing is drawing a line from each bone peak from the medial to the distal, and that's what should be possible. And so I think from this case, we got a pretty decent result. I could get a little bit more I'd be happy with, but we can't be picky. This is quite a good result for the amount. I mean, the dentist didn't think we could do this. He was quite impressed and happy. And you can see how nicely that bone is remodeled. It's, nice and solid. You can see here the difference between using autogenous bone and particular bone from other sources. Look how nicely remodeled and how clean that bone looks. You don't see any remnants of any bone chips or anything. Okay, so our next defect here is the anterior mandible. Here we have a slight vertical deficiency, but that's not a big concern because our implants would have to be placed a little bit more apically anyways to allow emergence and restorative space. Here, this was more of a horizontal deficiency. And you can see the lower anterior mandible is the least vascular of all the areas of the jaw, mainly cortical bone. So it's very hard to grow bone in this area. The other thing is augmentation in the lower mandible is difficult because you have to release the lingual flap, and the lingual flap on the anterior mandible is not released the way it is in the posterior. In the posterior, you can use that stripping method where you strip the periosteum off the mylohyoid muscle attachments. In the anterior mandible, you have to score and cut the periosteum, and this has to be done very carefully and slowly under magnification because there's a lot of vital structures and blood vessels and things that can get you in trouble here. And then the other thing is on the facial, you have all these muscle insertions, a mentalis muscle and things like that, which make flap release a little bit more difficult and more painful. We want to make sure you don't cut into that muscle because the patient's going to hate you for the next 2 weeks after. So with this case, we usually I like to plan, we used a bone block, but I planned the size and shape of the bone block ahead of time. So these are 3D printed models of the jaw. And then our osteotomy guide or our cutting guide for our block. So the block is seated. It usually seats on the teeth and is supported and then placed into the right side so we can check how it fits and seats. And then this is sort of the outline of where I need to cut. So our bone block is cut and removed. This is the day I didn't have my PAs when I had to use a drill to cut the bone block. Once the bone block is cut, we use a chisel and a mallet to sort of tap and release it off of the bone. The bone is then fixated to the right site with usually 2 fixation screws. And then in the void in between the block and the existing ridge, we pack in particular bone. And then once this is done, the site is closed up and this is what we get. And so because it's autogenous bone, you can re-enter sites like this in 4 months. It remodels pretty fast and nicely. So this is another view. You can see how that bone is attached. The screw is not, we didn't have resorption. I just unscrewed it a little bit just for the sake of the photograph. So here's the before and here's the after. So you can see now we have plenty of bone for the implant placement. We have the width that we've wanted, and these are incisor teeth. So even the implants that we place are going to be very narrow, usually in the 3 to 3.5 millimeter range. Our next case is a patient who had an atraumatic extraction. And when she came in to see me, she had these huge tori. You can see the mandibular tori on the top of the screen bulging out of the tissues. And so the extraction, she mentioned, was traumatic in the sense that either there was a large infection, but basically there was a big hole underneath the tissue. And when the dentist had removed the tooth, he had removed it, I think, because of pain in an emergency. And when he removed it, he knew that it would be a large defect that needed to be reconstructed. So he had sent her over. Usually he had sent her over right after, but I said, you know what, hold off, let's give it a month and then I'll see her. That's why you can see the socket is slowly starting to heal. And we took a look. So what I did first is I sent her for a cbct scan. And so you can see the large torus there as well. If you look on the left of your screen, that big black hole into the site, that's the defect. So it's quite a large defect in the area. Now, you can see that large amount of torus bone in the area. Here's a different view. You can see the bulge. So If you look to the left of your screen, you can see the defect, the remnants of the socket, and then that large amount of torus bone. So what we decided, because she said that they do bother her, is that let me use that torus bone. We can remove that and use that as a bone block, or we actually cut it into slices and use the plates to reconstruct a box around the defect. So here's a torus. You can see the toruses are good sources of cortical bone. It's not good to use as an entire graft itself because it's very cortical. There's no blood supply, so it's just dead bone. But it's really good to take that and cut it into slices and use the slices as cortical bone membranes. So here's a 3D rendering from the cbct scan. You can see the defect there, and just an occlusal view, you can see the torus there. So the defect, torus, so they're literally side by side. So removing that torus bone, you know, it is not painful at all to her. She actually will feel much, much better. Initially, she only wanted to do the right side because we're going to do surgery. I think she was a little bit hesitant to see how it would feel. After we had done the procedure, she wanted me to remove the other one. But I told her save it in case you needed another bone graft. This is a short video just explaining some of the virtual planning. I may just forward through some of this for the sake of time. So what we do is we just shorten the amount of bone that we need to work with. I don't need the entire model. I locate the nerve. And then we're looking at the defect. You can see the defect. And then we look at the site. So usually we work backwards. Remember, we put the crown in place, and then we put the implant. And now we look at the amount of bone ideally we'd require. So here, I'm just gonna forward. So here's our torus bone. So now this is the bone that we're gonna take. So I'm gonna be planning, so I can digitally plan how I'm gonna make my cuts. So, you know, that's the torus bone removed. That bone then is sectioned and cut into pieces to be used as our blocks to create our buccal plate. And then we'll do one on the coronal portion to close up the defect. I'm just gonna forward a little bit. So these are all our pieces cut in. And so this is just the pieces that we're just measuring them, making sure that they're the ideal size. And basically this is our surgical plan. So this is what we're going to use to complete the case. So what we do with all that digital information is we then print a surgical model. So this is our surgical model. And these are all the pieces of the tori. So it's done in different colors because they're different segments. So if you look at the larger segment on the left, that's the entire torus that we removed. Then that is cut in half, which will give us that segment in the yellow. That yellow is then sliced into two to give us the blue segments on the lower right side. Those are the segments that are going to be used as our plates to create our bone graft. And this is sort of what our plan is. We want to put, you know, one on the buccal, one on the coronal portion, and internally we're going to be packing particulate bone. So, you know, time for the surgery. We have everything ready, and you know, everything's sterilized and disinfected and ready for, you know, and usually I use these to kind of help me shape and trim the stuff so that I don't have to keep going back and forth into the mouth. I know that as long as I follow the shapes on these guides and have the model, I can do a lot of this just on the tabletop once I've removed the torus. So here's the surgical site. You can see the extraction site, it's still healing. There's granulation tissue in there because it was early in the time of the extraction. We didn't wait a couple of months. Literally, it was like 6 weeks and let's go. So there's the torus. Okay, this is the defect. These are 3D printed models. Torus pieces cut. Use a bone saw, or this is just a circular diamond disc saw to section the pieces, almost like slicing an onion. And here's our defect. We also use some of the torus to gather some shavings of our particulate bone. This is just a bone scraper. And there's our model. So once everything is kind of put into place, here's our plates of bone with the particulate and everything. So we basically followed our so-called digital plan. tension-free primary closure. We wait a few weeks. This one, I think we only waited 4 months. In 4 months, we re-enter, and this is our bone. So you can see it's nicely remodeled and nicely solid. Screws are removed. You can see everything is nicely mature. Lots of blood supply. You can see all the little specks of blood. These are all minor blood vessels, so it's nice and vital. Implant osteotomy. I want you to note when you look at this image, if you look at the top layer of bone, you notice there's not much blood supply. That's because that top layer is the piece of the torus bone. So you see, you don't get much vascularity in that, but then as you get deeper, it gets redder. So that's why I said it's not a good idea to just use the entire block as a graft. It's better to kind of use it as shells or slices. An implant in place, healing abutment, flap is closed, and this is once it was restored. Okay. And so it was our before and after. Our next defect, same concept. This is digitally planned. This is an anterior defect. Defects like this, you know, you have your nasal spine that's very sharp in there, and then you have these large dips. And, you know, we're sort of, as you go apically, it dips even more, and it's really, really thin there. So there's not even much marrow space. It's literally almost cortical plate to cortical plate. So cases like this, I like to use autogenous bone as well, because we create almost like a box around the area and put particulate bone in between the shells and remodel. And you get a better remodeling, I find, with autogenous bone. So in this case, I needed 2 blocks. So we created a bone harvesting guide to create 2 pieces of bone, one on the external oblique ridge more distally, and one mesially where he was missing a tooth. So we were able to just get a piece there. Now these 2 bone blocks were harvested, and then they were cut into half. So I had actually 4 pieces. Here's the bone harvesting guide in place with the ramus there. Here's the 2 pieces of bone removed from the jaw. Those pieces are then sectioned, and we get actually 4 plates. So I get 2 plates for the facial, and then I get 2 smaller plates for the coronal. So here you can see how the plates are then positioned further away, not compressed directly into the actual ridge. We're leaving space so that we can actually pack particulate into the void between the plates and the actual native ridge. And then the 2 other smaller plates are then placed on the coronal portion, and it's kind of packed in. And I use particulate bone just to sort of pack it around the ear to get rid of all the small defects. And a couple of months later, this is the site once we re-enter. You can see not much remodeling has taken place. The bone looks nice and solid once the screws are removed. You know, implants are in place. So we go from a larger defect on the right, where you can see a very prominent nasal spine and a large dip, to a nice, thick, large ridge where you have plenty of bone to work with. Now, this is our last case, I think, of the day, because I think I'm talking a lot. But same concept again. We've taken block graft harvesting and digital planning and sort of merged them. So we've taken, you know, computer-guided implant surgery into more of a computer-guided block graft surgery. So here we have is an anterior defect. We chose to use the chin as a donor site because I wanted, you know, from our planning, we wanted 3 actually flat blocks. And so we figured we can get the shape and size that we need from the symphysis. Here's a little video of some of the planning.
Do you recall not long ago when you walked on the sidewalk? Innocent, remember, all we did was care for each other. But the night was warm, we were bold and young. All around the window, we would.
So here you can see we're always planning crown down. Okay, so we see where the crown is, where the implant needs to be, and then how much bone we need. So you'll see this case has a small vertical component in the defect. But like I said, in anterior cases, you know, every millimeter counts for these cases. So we see our plates that we need, and we design the exact shape that we need from the actual defect. And so we, take that and transplant it into the actual recipient site, and we can tell now exactly the exact shapes of bone that we need for that site. So literally once we harvest it, and there's markings on that guide that tell me exactly where to make the cuts. So this is the guide itself once it's printed. And now we're ready for the surgery. This is once the blocks are removed. We also harvest some particulate bone as well with the bone scraper. And we fixate the blocks based on our proposed digital plan. In this case, particulate bone is used just to sandwich around the area and covered with a collagen membrane. So it's closed up. And so we basically simulate the entire surgery digitally so that, the actual surgical procedure is much simpler, less guesswork. And then usually a couple months later, we go in, and in this case, it was a guided implant surgery. So we looked at our implant guide details. This was our guide. And this is a re-entry of the site. So you can see that the bone defect has fully regenerated. You can see all 3 screws are, little to no resorption at all. And what's nice is if you look, see how nicely these bone plates have been sort of unionized and matured. You can see as I'm removing the screws, there's bleeding. It's bleeding from the screw sites. So it's vital bone. You can see it's fully remodeled. It's nice and solid. There's no pieces of particulate. Implant osteotomy is completed with the surgical guide. Implant is placed in place. And there we go. So we also did a pedicle connective tissue graft to hold it in place to get a little bit more tissue contour because of the way her teeth were shaped. It was difficult to shape a papilla in this area, but we're going to try to get as much volume as we could. And that's the case. So I'm going to end now. I'm currently actually working with Stephen Phelan. I don't know if any of you guys have heard of him. He runs an online platform for restorative dentistry. He does a lot of work with veneers and full mouth reconstructions and altered VDO in cases. And I think a lot of people know him already or have taken his course. So he has a fantastic resource and portal on his page, and everything is available online. So he actually is one of my good friends and referrals. We do a lot of cases together in Oakville. And so one day he mentioned that, hey, let's do an online course for bone grafting. And so within this time of COVID and us sitting at home, we kind of put it into high gear and are launching this soon. So we are giving a webinar this Saturday to sort of launch the online course, as well as you give some free information just to see if it's something you'd be interested in. The information is here available on the page. You can basically, I'll put up the links in a second so you can, this is all the things that you're going to learn during this webinar. Basically, it's going to focus more on a step-by-step approach to treatment planning and how we look at the case and analyze defects and decide on our treatment plan. And all this information is available on the web page here. So if you guys are interested, take a picture with your camera. It's just, Phelan Dental Seminars is a website. So phelandentalseminars.com/GBR-webinar. Okay, so you guys can sign up. The webinar is free, so all of you guys feel free to come in and sign up and watch it. And then we will be launching our online course at the end of it. if any of you are interested in learning some of the bone grafting and some of the procedures that I do and how I do it, then, this seminar is geared towards beginners. So it's geared towards assuming that you know nothing, and it's teaching you, it's very sort of hands-on, and we go through very technical details, all the things that you sort of never really get or understand in regular courses. We're going to focus on that aspect to make it a little bit different, so that anyone who takes this course will hopefully be able to do bone grafting, very comfortably and very easily in their practice. Okay.
Nahid, that was absolutely incredible. Thank you for putting.
Sorry, I went over a little bit there, but
No, I think that was great. And also the first time that I personally see autogenous grafts that were being planned digitally. So thank you so much for sharing that. And just for all those who are listening, that this is very, very high level stuff. I did quite a bit of learning in Germany with Frank Zastrow, and even he wasn't teaching it at this level when it came to digitally planning it. So thank you so much for sharing that with us, and we really do appreciate it. So I'm going to bring on Waqar and Ziad again, just to ask some questions. But before that, we're also going to just do a couple of housekeeping items as well. So all of these videos are going to be uploaded to the Dentistry Academy YouTube page. So please make sure that you subscribe to the page as well. And also make sure to follow us on LinkedIn and Instagram. Friendly reminder of tomorrow's topic. It's going to be an endo-related topic. We have Dr. Jorge Moreno, who's going to be speaking to us about pulp therapy, along with Dr. Aldo Mansour, who's going to be speaking on the diagnosis and management of dental resorptive defects. Once again, these will be starting at 11 a.m. tomorrow, so please feel free to join us. So what I'm going to do here now is pass the mic on to Dr. Waqar. I guess we can say that now, right? For some Q&A.
Well, not quite yet. I think we still have to graduate and get our degree.
If you're not going into school anymore, you're Dr. Waqar from now on. So you're good in my books.
Sounds good. I just wanted to say thank you, first off, both to Dr. Mohammed and Dr. Kokosis. Honestly, dental school is often busy, and there's not enough time to delve into these topics. And if you talk to dental students about perio, we don't see this. It's hard to see this big picture. So I just wanted to say thank you, and you guys both presentations did a great job of taking these complex perio topics and kind of breaking them down. So we'll get to the questions. The first question I have here, it's for Dr. Nahid Mohammed. How accurate do you find the digital workup to be?
It's pretty accurate. So if you noticed, it depends what part of it you're asking. Like, everything can only be as accurate as each step. So for example, when you look at the jaw models that are, everything comes from the DICOM data. So what they do is they segment the bone and the shape off of that DICOM data. So if you're not careful, or the segmentation is not done right, then you can lead into inaccuracies. Same thing with the guides. If the guide is not seated right, I don't know if you guys noticed, but all the guides I use were tooth-borne, meaning they seat on the teeth. So what we do is we take an intraoral scan, so we get a very accurate registration of the teeth, and then the guides sit on the teeth to make sure that it is exactly where it's supposed to be. Whereas sometimes if you have it seated on the bone, if the segmentation is not done, then there could be a small discrepancy. So in that sense, if it's not done correctly, you can have room for error and mistakes, but you have to kind of work with, I get my segmentation done by people. I don't do it. So it's, you have to get someone who does it well.
Gotcha. Okay. The next question is actually from a young dentist. Do you have any advice for young dentists who are starting off with ridge preservation? And I guess this goes to both presenters.
Well, ridge preservation, learn how to do it right. To be honest, there's a lot of courses and a lot of things out there. I think, to be honest, the hardest part of ridge preservation is the extraction itself. So if you get the extraction out, doing the ridge preservation is pretty straightforward. So get good at extractions, and the rest is, I mean, the ridge preservation is literally putting bone in a hole, and just learning to place that membrane in nicely, or collagen plug and suture it close.
Mm-hmm.
So take a good course, I guess.
And I guess a follow up to that, what are typically the success of no membrane graft options?
In what sense? I guess.
In terms of immediate ridge preservation for post extraction. Yeah.
So, for example, an extraction socket. So, an extraction socket is technically what we call a four-wall defect, meaning that you have four walls around it. So, it's very predictable. I don't always use membranes in an extraction socket where I know all the walls are stable. Usually, I just use bone and a collagen plug, and you get bone. So, it's pretty predictable. It's usually in cases where you want absolutely no loss of vertical bone, then I would use something like a cytoplasm membrane. But again, it's not always necessary. It all depends. Some of them you'll get great bone, some of them you'll have a little dip because the patient got something stuck in there. So if you want to be safe, you want to keep a secure cytoplasm membrane to keep everything safely closed and sutured nicely. But it's not always necessary, no.
Gotcha. The next question comes from Kate and Omar, and it has to do with suturing a membrane over a graft. And you mentioned that you use sutures to kind of stabilize or anchor the membrane. What are the sutures being attached to? How does that work?
So the suture, so what I do first is, remember, I always score my periosteum first after I release the flap. I try to make my score of my periosteum at the base of where my graft is going to end. And so if you think of the periosteum as two layers, once you score it, they split. The bottom part is what I tack the suture to. So I go from the lingual or palatal flap from the outside, go in, and then go over the membrane into the flap, and I go into the bottom part of the periosteum, engage that, and then pull it back over. So it's the periosteum itself that you're using.
And that keeps it kind of stable.
Yeah, and the reason why I go below the cut is because if you go above the cut, that's the part that's movable. So when you close the flap, it's going to move. If you go below the cut, it's below the stretch. So you make sure it's secure. But yeah, it is the actual internal part of the flap that you're going through.
That's pretty cool. The next question is, in an event of an area where there's recession and you want to graft, how would you treat the neighboring roots prior to placing your bone graft?
Like gingival recession?
Yeah.
It depends. I mean, sometimes you have to decide what's the cause of the recession. If you have bone loss in the area, then gingival recession on its own, treating it is not going to be predictable, because the tissue is supported by the bone. So if that's a concern, I'm a periodontist. So usually it's easy for me to do a tissue graft and the bone graft at the same time, which sometimes we do. If there's a neighboring tooth, we just take care of it in the same appointment because you are coronally positioning the flap. So I just add some tissue graft there and coronally position everything. In some cases, if it does have a lot of bone loss, it may not be predictable anyway, so I wouldn't bother. So if it's, let's say, assuming a treatable defect, then it's pretty easy. I just design my flap to make sure that I can cover that root with the tissue graft and then position that tissue in the right place at the same time as doing bone graft. So there's slight modification in the flap design, but I would usually do it at the same time. You can do it at the same time as a bone graft, or you can do it when you do the implant. Both work.
Gotcha. Okay. The next question we have here is from Dennis. He asks, how are you disinfecting the implant prior to bone graft placement?
Depends. My protocol usually involves tetracycline, peroxide, sterile saline, and usually burrs and like a titanium brush to clean the surface.
Gotcha. Next question is from Abdul, and he asks, is the autogenous bone taken from the mandible? I think this is referring to some of the block bone graft
Yeah,
state?
so my majority of my harvest sites usually come from the ramus external oblique ridge area, so the posterior mandible. And then if I'm working in that area, then I'll use the chin, but usually I don't go to the chin unless for some reason I have to, or I'm in that site, because it's more painful in the chin than it is in the ramus.
Cool. And our last question's from Natalie, and she was asking, do you use a particulate bone graft to regenerate the bone block donor sites?
You know what? If I have some extra, I usually put it in. It's not absolutely necessary. It usually tends to kind of remodel, but it depends how large the defect is. But yeah, if it is a large defect after, I'm not more worried about the regeneration, because it usually will, but the packing of the bone does help sometimes with just controlling the bleeding and hemostasis. And it gets rid of sometimes rough edges and things like that.
Right. Okay. I believe that wraps up the question. So I'm going to toss it back to you, Hisham.
Awesome. Thank you so much, Wakar. That was good. Well done. And you know, in 3 or 4 years, hopefully we'll have you on the show, right? So thank you guys. And I wanted to thank our co-hosts, Dr. Jeff Sumner and Dr. Ziad Hamad. And I'd like to thank our speakers today as well, Dr. Tina Kokosis. She did an incredible job. So thank you, Tina, for that. And Nahid Mohammed, you honestly raised the bar in my eyes on so many different levels. So thank you for sharing all of your cases, and thank you for sharing your knowledge with us. We truly do appreciate it. And we know it's very tough for you to do this, especially during Ramadan when you're fasting, to talk for that long. So from the bottom of my heart and our heart as well, it means a lot to us that you'd share your experience and your cases with us. That wraps up everything for today, everyone. We're looking forward to seeing everyone tomorrow at 11. Once again, these are all recorded, so they will be posted on the Dentistry Academy YouTube channel, along with following us on LinkedIn and Instagram for any upcoming updates. And for the upcoming courses, please feel free to sign up for them at dtacademy.ca. A lot of these courses are getting very close to capacity, so my recommendation to you would be to sign up early. One other thing too is that we've been having a couple of people who have had a hard time signing on. For security purposes, we've allowed that only authorized users can join our channel. So please make sure that you register with Zoom your account. That way, when you join our chat lines, you won't have any issues logging in. So once again, thank you guys all for your time today. And we're looking forward to seeing everybody tomorrow. Have a great day, guys. See ya.
Take care.